name is Mindy Webb. I'm a licensed clinical social worker, and I'm the behavioral health care coordinator with the Delaware Child Psychiatry Access Program. And we're so pleased to see such a great large audience for today's presentation with Dr. Colleen Leitner around pediatric bipolar disorder.
Let's get started. I have no significant financial disclosures. In planning a pediatric bipolar lecture, I think somebody asked me, why is your goal that primary care clinicians are going to be the people, primarily treating pediatric bipolar? That is not my goal at all. My goal is really to have this as sort of a mythbusters. I would say that bipolar disorder is the #1 diagnosis that my patients think they have, that I am sort of dispelling and saying, I don't really think you have this. I don't think you meet criteria in our current definition of bipolar disorder. And part of that has to do with some historical context, and I'm going to go into. So I'm going to explore a little bit of the historical context. What is the real epidemiology of this? Define clearly, how do we define bipolar 1 and 2? How does this present in kids? And then some of the background of differential neurobiology, some clinical pearls. And then I'm going to present treatment options, not to say, okay, this is exactly how you should dose lithium and when you add an augmenting agent to that, but mostly present where the evidence is and an overview. Some recent historical context. So pediatric bipolar has been very controversial. I would say it's like top 3 most controversial psychiatric diagnoses right now. Clinicians agree it exists. The symptoms mirror those in adults. The issue is how narrowly or broadly to define mania. So before the 90s, we almost never diagnosed pediatric bipolar. If kids were psychotic, we said that this was schizophrenia. It was something we really wanted to work on. So in the 90s and 2000, a specific group did a lot of retrospective studies with adults with bipolar. They were looking back and saying, actually, before my first manic episode, I had a lot of mood dysregulation. And so there was an effort to say, okay, can we work in a preventative way? If we diagnose people earlier, get them on mood stabilizers, could we prevent a significant fallout of big manic episodes? A few things happened around that same time. So this is the 90s. This is sort of the birth of a lot of use of SSRIs in kids, atypical antipsychotics, and there was a change in the ADHD diagnostic criteria where emotional dysregulation was removed. So suddenly we have these chronically irritable kids with emotional outbursts. We're calling bipolar for the first time, and we have atypical antipsychotics. So when all you have are hammers, everything starts to look like a nail. So we're labeling people bipolar and then using atypical antipsychotics for emotional dysregulation. There's a lot of pushback on this in sort of the early 2000s. In 2013, DSM-5 came back and said, we are narrowing the definition of mania. We need to change how we're identifying pediatric bipolar. Because it turned out that these kids with emotional outbursts weren't necessarily becoming bipolar as adults. We also added a new diagnosis to capture these persistently irritable and emotionally reactive kids, which is disruptive mood dysregulation disorder. So, basics. When I say mania, what do I mean? Dig fast is sort of what I learned in school. So, distractibility is being distractible. So, having your attention drawn to irrelevant external stimuli. Impulsivity, when I talk about mania, is less sort of ADHD impulsivity that you sort of make a decision and then you're like, oh no, facepalm. It's more pursuing pleasurable activities in an unrestrained way. So I had a college student who was a very typical college student. He was an engineer and in a fraternity, and he became obsessed while manic with buying antiques. So he spent like $20,000 and kept opening new credit cards to buy antiques. At baseline, he has no interest in antiques, but this was sort of like his manic activity brought him that way. Grandiosity is inflated self-esteem. So more than just I'm self-confident, but I believe I am the best one. And often that's in an irrational or delusional way, like I am a messenger from God. Flight of ideas. The key here is this lecture could be a flight of ideas, right? I'm talking and talking and talking, and you guys aren't really interrupting me that much. It's difficult to follow for others. So if someone were to try to keep up with the ideas, the flow between ideas doesn't make sense. And then activity, an increase in goal-directed activity. The classic would be it's physical and mental, so you're up all night pacing and writing a manifesto. Decreased need for sleep. So not that you're not sleeping because you are up and you're anxious and then you're feeling very poorly rested the next day, or you're sleeping in, but you absolutely do not need to sleep. You sleep for a couple hours and you're like, I'm going to conquer the world. You wake up excited. And then being more talkative than usual. Some people are at baseline talkative or a pressure to keep talking. So when I say someone has pressured speech in my mental static exam, what I mean is they are not interruptible. So they will talk and talk and talk. And I try to say something and they just keep talking regardless of what I'm saying. So how does this show up? So in the DSM, the criteria for mania is a distinct period, and I put in red some of the things that were emphasized in the DSM-5 definition. So you have to have a distinct period of an elevated, expansive, or irritable mood going on for a week and present most of the day, nearly every day. So this is not like 1 minute or 1 hour. It's 1 week, and it's a distinct change. It's not shifting throughout the day. It has to be a noticeable change from your usual behavior, and you have to have 3 of the dig fast symptoms. So criteria B is sort of the dig fast. 3 of them, or 4 if you're just irritable instead of elevated or expansive in your mood. It has to cause marked impairment that others notice. So either you're hospitalized, you're psychotic, or you cannot function in relationships or at work or school. And then it can't be due directly to a medical issue or a substance. So once you hit that manic criteria in DSM-5, you have bipolar 1. So you can diagnose bipolar 1 with mania med. Depressive episodes are not needed to diagnose, but usually they're present and often they're preceding a first manic episode. Hypomania can also be present, so sometimes you'll have a sort of a hypomania that evolves to be a full manic episode, but also not needed to diagnose. Bipolar 2 is a little different. You need to have met hypomanic criteria, which I'm going to present on the next slide, but you also need to have had major depressive episodes, unlike bipolar 1, where once you're manic, you're assumed you've had it. So this is hypomania, very similar to mania, just a change in the time course and the level of impairment. So it lasts 4 consecutive days, similar thing, present most of the day, nearly every day. Criterion B is the same. You need 3 or 4 from dig fast. So it's not like, oh, they have a hint of a whiff of mania and that's hypomania. No, you still need 3 or 4 dig fast symptoms. It has to be an unequivocal change in functioning observable by others. So that's subjective, like, I felt really productive the last 4 days, that we all get, that's part of normal life. That is not hypomania. But it can't be severe enough to cause marked impairment or need hospitalization or have psychosis. That would be something else. And then it can't be similar to mania, attributable to medical issue or substance. Okay, so how does this usually look? Bipolar is usually these recurrent discrete episodes, and then you return to baseline in between. So mania, we want to think of as a collection of concurrent symptoms, the dig fast symptoms, and a mood shift, not just a list of symptoms that occur in temporal isolation. So if you're occasionally irritable, occasionally impulsive, occasionally you sleep poorly, or you're boastful, that is not in and of itself mania. You need to have this clear shift that you can separate out in time. Untreated, mania lasts months. So, this idea of like little blips of energy, throughout the day or the week, that would be more normal. That would be more the typical person. If you are up and up and up and you're not needing much sleep for months on end, that would be mania. The most severe sort of number of episodes, so like the top 10% of individuals with bipolar in terms of how many episodes they're having would be for a year, and that we consider rapid cycling. That's unusual. So that's 10% of the 1% of individuals with bipolar are rapid cyclers. So if you have 2 depressive episodes and 2 manic episodes, suddenly you're a rapid cycler. So usually we're having 1 or 2 episodes in a year that last a few weeks to months. When we do have psychotic symptoms, and psychotic symptoms are common, so 75% of individuals with mania will have psychosis, it's usually mood congruent delusions. So people will have grandiose delusions. So this belief, I'm a messenger from God, not necessarily audio or visual hallucinations. Particularly with bipolar depression, we do not see many hallucinations. So if I see a kid who is having persistent voices telling them to harm themselves, and especially if they're not necessarily correlated with mood episodes, that is unlikely to represent bipolar disorder. I'm thinking this is probably something else. So some key considerations when I'm thinking about mania. Because it's a discrete shift from usual mood and behavior, I need to know the kid's baseline. How are we shifting? Particularly with impulsivity and irritability, which are ubiquitous and really common in other childhood disorders. I need to know a developmental history. So what would be their usual risk tolerance? Where are they socially? What is their ability to regulate their emotions? And then the context where symptoms occur. Manic symptoms should be pervasive. If you are truly manic, you can't contain this at school, but then you end up manic at home or only on the weekends or with certain peers. So kids will be influenced by the context in which they're in, right? So if you ever go work in school, it's like, oh my gosh, this is so different than the way my kid behaves at home. And that to an extent is normal. That would be typical. And then finally, the extent to which symptoms impair the functioning of the youth. Though collateral informants are really good for this. If you can speak with people from school, the parents, friends, anyone else that can sort of get an impression. Often what will happen is someone manic will not think there is anything wrong with them, and everyone else in their life will be scared. So some examples where these things come up: if you take 7-year-olds at a birthday party or adolescents at an amusement park, they all look manic, right? They're running around, they're screaming, they're impulsive, everyone's a little afraid. What are they gonna do? But the hope is that this is not pervasive. So we shouldn't behave in this way, in this sort of like reckless, euphoric, hyperactive way in every setting, right? It shouldn't persist. And then in terms of developmental course, we have these natural breaks where there's a shift in emotionality. So when an infant becomes a toddler or a school-age kid becomes a teen, we go from being, with the infant to toddler, we have this sweet little baby, and then suddenly they're a toddler and they're irritable and they're angsty and they have big feelings as they're trying to define their autonomy. Very similar process when a school-age kid becomes a teen. And so that's a sort of natural developmental course that I would expect. We're having a shift in how emotional you are. It's very gradual. It's appreciable by others, but it's part of an appropriate developmental phase. So I'm always trying to tease out, like, is your increase in emotionality something I would have anticipated? Is it sort of gradual in onset, or is it more discrete and acute? And that's what I would expect for mania. And then sometimes we'll have kids who we're trying to figure out, are things episodic, but it relates to a stressor or a situation. So sometimes kids will be irritable only at a certain person's house or only a certain activity like school, for example. And often I'm thinking about, is there a trauma happening or is there an anxiety more likely? It shouldn't be, again, contextual or situation specific. So some notes on antidepressants and bipolar. Antidepressants, including SSRIs, can precipitate hypomania or mania in vulnerable individuals. DSM-5 basically says if you stop the antidepressant and you are still fully syndromal manic, even when it's out of your system, call a spade, that's bipolar disorder. But with that said, be cautious. Don't take one or two symptoms. Oh, sorry.
We have a question?
Yeah.
Had you been able to get on and look at the PowerPoint?
If somebody can mute their phone line, if they're in listen only, that would be helpful, or please do ask a question if you have one.
Yeah. Yeah, so basically, if someone has a reaction to an antidepressant with some irritability and edginess, is this the medicine? Is this, the depression alone? Hard to say. Make sure you are looking for the full manic syndrome when you're diagnosing it, not taking irritability or edginess coming off an antidepressant or being on one as sufficient for bipolar. And in kids, it's even more important. 10 to 20% of kids, if you give them an SSRI, have activation. So they will have this sort of non-specific increase in anxiety, irritability, and energy level. And that doesn't mean that that's hypomania or that that kid can't take a different antidepressant. I see it most with fluoxetine. So say somebody has a fluoxetine trial, I might try sertraline or escitalopram as an alternative. But I wouldn't label them bipolar. I'll have kids come in all the time and the families will say, well, they can't take SSRIs. They had this one where they were off the wall. And I will do another trial. Okay, now I'm going to present some cases. This was a study that was cited a lot. It was a British study. So Americans, right, in the 90s to 2000s, we have a 40-fold increase in the number of kids we're diagnosing with pediatric bipolar disorder. Europe, everywhere else, they're not mirroring the shift in how we were diagnosing. So basically this British group did a study where they presented a bunch of cases. They asked British and American psychiatrists, what do you think this is? And this is one that everybody agreed, over 90% said this is bipolar disorder. So I wanted you to sort of get a feeling for that. So Nicholas, 12, she used to be shy, helpful, academically typical. Suddenly, she has an onset of behavioral changes. In a few weeks, she's dressing in revealing clothes. She's talking to strangers by the phone and internet. She has increased energy all the time and extreme mood changes. So she has what we'd call lability. She's laughing hysterically 1 minute and then swearing and smashing things the next and crying without provocation. She has a history of depression. She recovered with therapy. When you observe her, she is noticeably agitated. She's talking loudly. She's has rapid speech. She's bragging that someone will call her that's a famous actor. She has this increase in activity. She's organizing toys. People are trying to redirect her and she's yelling at them. She's suspicious on interview. And then she's really angry when you ask her about drug use. She has a family history of depression, alcohol use, and postpartum depression. So this to most people was mania. This would be a more predominant irritability. And what's key, I think, is that sudden onset over 2 to 3 weeks and a clear shift that we can differentiate from her baseline. Okay, so this next one, I'll just present it and sort of maybe see what you guys think. So Linda's 11. She's always been hyperactive, disinhibited, and impulsive. She got put on stimulants for presumed ADHD with only partial resolution of symptoms. She can't sit still. She's talkative. She's oppositional. She is intrusive and bossy with peers. Over the past year, things have sort of been heightened. She's been increasingly angry, irritable, provocative, destructive, and capricious. She's bullying little kids. She's expressing interest in lewd material on the internet. She's a show-off, so when people are around, she tells all these jokes and seems to like this. She rages when she does not get her way, and this could last hours. She would scream, curse, throw dishes, and had threatened others with a knife. She had a history of being in a psych ED. On interview, she's calm, sort of rude to her parents. She can focus, but tries to control the flow of conversation and ask a lot of irrelevant questions. She reports being distractible, forgetful, and restless. She says, I'm sad, I've been suicidal, and I have all these mood swings. My moods are all over the place. And that's probably when people are coming to me saying, I think my kid has bipolar, it's the mood swings. It's the 0 to 60 that they like to report. She denied euphoria, but said her speech was rapid, but we didn't notice this when assessing her. She reports insomnia, but on description, she's going to bed at 1, but then sleeping till 3. She reports using tobacco and cannabis and has a family history of depression, hypomania, and ADHD. Any thoughts on what the Americans or British said about this one? Anybody? It's sort of a trick question. So basically, like, none of the British psychiatrists thought this was bipolar, but a small majority of the Americans did. With the current narrowing, so post DSM-5, this would not be pediatric bipolar. She would, depending on how often she's having these rages, if she's having them 3 or more times a week, she would meet criteria for DMDD because she's had a year of irritability. And you could have a comorbid DMDD and this previous ADHD diagnosis. And that probably is, this is sort of like where DMDD was supposed to come in. So clearly this girl has significant psychopathology. She needs significant support. You know, she's been to the ED and the other kid hasn't. But it doesn't quite fit our classic bipolar disorder, of course. Questions about that before we move on? Okay. So what does the course usually look like? So there's a 1% lifetime rate. It's highly recurrent, episodic. Bipolar in kids, it really depends on how we define. Our most recent data says about 0.6% in adolescents. The average age at first manic episode is early 20s. When kids report, oh, I think I have had mania, that's really common in the general adolescent population, which is why collateral is so important and why our sort of 90s studies didn't pan out as we thought we would. Early onset bipolar under 18, regardless of how we define sort of our 90s 2000 definition versus now, is associated with some more severe pathology. So a slower response to treatment, an increased risk of suicide attempts, and severe psychosocial impairment. So 20% for suicide attempts is remarkable. Comorbidities. Classic bipolar is preceded by anxiety and sleep disorders, and then at times a major depressive episode, or what we will think is a major depressive episode. So you'll have sort of these like at least 2 weeks of depressive symptoms, and we'll often label it unipolar depression, treat with SSRIs, and then not get the response we'd hoped for. Peripartum depression is really common in individuals with bipolar 1, so up to 50% of pregnant people with bipolar 1 will have a peripartum episode. In more broad definitions, 90% of kids with prepubertal mania met criteria for ADHD and ODD, but in the classic definition, it's not occur more commonly in controls than in the general population, or than in controls or the general population. So I would not say ADHD is associated with bipolar. Drug and alcohol use are more common, and sometimes it can be hard to tease out the diagnosis because drug use can cause what looks like a euphoria or what looks like a depressive episode, and then as well as a psychosis. So if someone's using like cocaine or methamphetamine, it can be difficult to say, okay, is this a true mania or is this just related to you using drugs? So that requires sort of a little bit more thoughtfulness on whether or not we'll continue to treat as a maintenance therapy versus just encouraging or treating substance use. Some remarks on genetics and neurobiology. This is a highly genetic disorder, so genetic influence explains 60 to 90% of the variance. Major depression is identified when we look at family trees, though. So it's not that we'll see bipolar all over the place. We'll see clusters of major depression more often. There's a great interest in uncovering the brain mechanisms. The research is complicated by the heterogeneity, not just within the disorder, or not just within how we define it, but within the disorder itself. So like we have depression, mania, and then sort of maintenance phases. And so it's difficult because these mechanisms seem different. Different things are going on in each phase. There is data support sort of brain structures related to emotional reactivity as being involved. So connections between the amygdala and the anterior paralimbic cortices. So what's my differential if someone comes in with symptoms that seem like mania? The first three, ADHD and then disruptive behavior disorders and DMDD, that would be more our case 2, our Linda. I'm thinking about those things. Unipolar depression, so if someone's coming in depressed, in the back of my mind is this a bipolar depression or is this sort of major depression? Particularly when I have an anxious depression. So sometimes if people are really anxious when they're depressed, they don't sleep well at all, and they can have this frenzied energy and irritability that feels a little bit manic. Autism, so kids with autism can have sort of episodic shifts in behavioral dysregulation and aggression that can almost appear like, are they going through a depression or a mania? And then sort of when you're pulling things apart, there's some stressor or something going on, a medical issue. Not that kids with autism can't have a comorbid bipolar disorder as well. Schizophrenia will present with more prominent psychosis and fewer mood episodes. Substance use disorders, I touched on this when we were talking about cocaine and cannabis. So they can precipitate psychosis, but then also we can have this sort of discrete mood episodes, whether or not you're using or withdrawing from substances. When adults come to me and say, my emotions go 0 to 60, they rapidly shift, I have problems with impulsivity and I don't know who I am, I'm thinking borderline personality disorder. And even in adolescence, I can give that diagnosis. So sometimes that's something to think about as sort of the dimensions of personality with shifting emotions, particularly in adults when personalities are more set. Medical problems can cause symptoms that mimic mania and psychosis. So delirium is the classic, but also more rare things like an NMDA, encephalitis, or Wilson's. Medications can precipitate mania, steroids, the classic, more so in adults, but it can happen in kids, and then stimulants as well. And then finally, trauma. So kids that have gone through trauma can have what looks like discrete mood episodes depending on their repeated exposure to trauma, but also kids that have gone through trauma can have sort of rapidly shifting emotions and increased emotionality that might look a little bit manic. So when I'm thinking, is this ADHD or a disruptive spectrum illness versus bipolar, how am I differentiating? So kids with ADHD will be silly, they'll be disinhibited, braggadocious at their baseline. Bipolar would need to be a change, right? So if they're already silly, it would need to be like silly times a million, right? It would need to appear very different than their usual silly. Kids with ADHD might be impulsive. Bipolar 1, it would be pleasure-seeking, sort of like we discussed. Kids with ADHD might not want to go to bed and have a lot of energy. In bipolar, you would need a decreased need for sleep, and you're going to be planning all night, which my ADHD kids might not really be doing. You might see a shift where you have an exacerbation of subthreshold and attentive symptoms when you start middle school, but in bipolar 1, you're going to have this new distractibility, and your ideas are flowing in a way that I can't keep up with. I'm going to show an example of flight of ideas next, but it's not just, oh, I'm distracted by details, but this is hard to follow. ADHD can also progress to include more oppositional or explosive behavior, but there's that thread in their developmental history of impulsivity. Whereas bipolar 1, you'll just have this episodic irritability that's just happening with the mood episodes. And then finally, most kids with ADHD are quite talkative, or they might speak very rapidly. But in bipolar, we're having this flight of ideas. They're not interruptible. They're filling the space. Disruptive behavior can also resemble mania. So kids with conduct disorder, which conduct disorder is sort of the more severe form of ODD, the precursor for antisocial personality disorder, they might be irritable, they might stay out late, they might have sex, use drugs, and they might not care that much about other people, which can seem a bit grandiose. If behavioral problems are only happening during mania, depression, and disappear when mood gets better, don't make an ODD or conduct disorder diagnosis. In the same way, consider bipolar if their oppositional symptoms only appear during mood episodes. But if these were present before and present all the time, it's less likely to be manic. And then if they had oppositional behaviors before, you could, and then you had the superimposed mood episodes, both diagnoses could be given. Came in manic and psychotic. This was a teen. His handwriting's not that great, but it says orange, sun, SunTrust. So SunTrust is a bank. So this is what I mean when I say flight of ideas. He is moving in a way where the associations between his ideas are loose and they don't make sense to me anymore. Over on the left, he says AM, PM, sunrise, and then subset. So now he's moved from the time to math. And then from subset, he went to 3 digits, 4 digits, arrow, 2 digits. I don't know what that means. I don't know what the relevance is, but he's down to subsets. So the way the ideas move, he is really off, taken flight. It does not make sense to me. It's not just that there's a lot of ideas. And then the top, there's some meeting that he was supposed to go to at 7 a.m. and then 00, 5 to 6 minutes. And again, like none of these things are related to one another. And the whole sort of notebook was like this. Here's an example, it's a little blurry, but of him later on when he had sort of consolidated, he was still disorganized. There was a little bit of loosening, but he wasn't fully taking flight with his thoughts. So the top part was his workout schedule that he had planned out. So the far left circle is he wanted shoulders to be boulders. He told me that was like a really appealing thing. Boulders, front, middle, rear, dips. And then he was going to do 18 of those and then move on to his torso. And then like you could see there's sort of, and then total body, knees, elbows, 21, 22. There's like some logical thought to this, but then it also really doesn't make sense because he's doing 16 plus gluteus maximus, spine erector equals 17 plus 1 equals 18. Like it doesn't quite make sense in a logical way. So it's not completely logical yet. He's still disorganized. And then at the bottom, he really didn't understand why he was there. So he kept trying to figure out like, okay, who is this team that keeps meeting with me? Why am I here? What's going on? So he wrote my name, Dr. Leitner, but he wrote Dr. Lightyear. So he's like flipped. Again, this is loosening. He's going to Buzz Lightyear, I think. And then Dr. Bond, the other physician, and then 3 Dr. Boy. I don't know what he means by that. We were all women. I don't know. It makes no sense. And again, it's like this disorganized to an outside person. It should not follow a logical flow of ideas. I think when we think about psychosis, we're often thinking about auditory and visual hallucinations, but more indicative of true psychosis for me would be this sort of thought disorganization. And then you can see the social worker is Chelsea, so there's just a 3-person team. But then he wrote over here my name again, but then he wrote it backwards. So not really like fully understanding. And then way at the bottom, he's gone back to his workout routine, head and shoulders. And then his COVID test was normal. He wrote that on the right. So still some disorganization and flowing between ideas in a way that's hard to understand for the other person. And if he was speaking out loud, because the volume of pages he had in this notebook was vast, it would be really, really hard to keep up with. Okay. Going to touch briefly on treatment. If you don't remember anything, this slide is key. Medication is first line. Psychosocial intervention, so therapy, you can add on to medication, but unlike depression or anxiety, where I would say you can start with therapy for mild or moderate symptoms, I would not say that for bipolar. We divide treatment when we're doing research to acute treatment of mania, acute treatment of depression, and then maintenance. Atypicals have considerable effectiveness. Sort of for all 3, I would say they would be first line for kids with bipolar. This is in contrast to our adult treatment. So divalproex and lithium would be sort of our mainstay mood stabilizers in adults. They have more mixed results. So lithium in adults, 33% of adults on lithium with bipolar 1 will go 10 years without a single mood episode. And then like 70% will go a full year without a mood episode. So you'll see the results in the next few slides. This is when we started to say when our lithium studies weren't even beating placebo, we were starting to say perhaps whatever we're calling pediatric bipolar is very different than what we've been calling adult bipolar. There is no indication in kids for oxcarbazepine, carbamazepine, or topiramate in pediatric bipolar. So if you have kids who are going to the hospital getting diagnosed with bipolar and being put on one of these medicines, I would have questions. All right, so here are the therapies with evidentiary support in bipolar, child and family focused CBT, individual family psychoeducation, so really just talking to families about what bipolar is, family-focused treatment, and then dialectical behavioral therapy, which is sort of our borderline personality disorder treatment, but also has some indication in adolescents for other disorders. This is a busy slide. Essentially, lithium and 5 atypicals have FDA approval. So olanzapine, risperidone, aripiprazole, quetiapine, and asenapine. Ziprasidone had a good trial for mania, but doesn't have FDA approval. Industry-sponsored trials for carbamazepine, oxcarb, and topiramate were negative. We tried 3 different times, though if you look at the dates, all in our sort of expanded definition of mania, to compare divalproax with an atypical, and each time the atypical really outperformed the Depakote. So 68, 72, and 78% versus 24, 40, and 45. The team study is another example where we really tried to see how lithium would respond. We didn't beat placebo, it was 36% response rate. This is our gold standard treatment in adults. But when you look, that study came out in 2012 and 90% of those individuals had comorbid ADHD and ODD. So I think this is a study that's often referred to when we say we've sort of lost sort of the true gold standard bipolar, and therefore our gold standard treatments weren't working. Adolescent onset classic mania has demonstrated lithium responsiveness. So if I have an adolescent who seems to have classic bipolar, I will use lithium. For depression, trials are limited. There's 2 things with approval, olanzapine plus fluoxetine and lurasidone. Quetiapine did not beat placebo. Uses of antidepressants plus lithium or Depakote are less useful in kids than adults. We always talk about weighing the risk of precipitating mania or hypomania. So if someone has a strong family history of bipolar disorder and I'm sort of convinced the family member has a true bipolar, I will still start an SSRI, and then I'll monitor for response and for mania. Like we discussed in the family history, often what we're seeing is we'll have bipolar in a family and then a lot of other people with depression, not necessarily everyone having bipolar. And then trials are limited in maintenance. We commonly use atypical antipsychotics based on the evidence for depression and for mania. Lamotrigine maybe had a benefit, and then patients stabilized on lithium had a lower risk of relapse compared to placebo, though nothing like our adult data. I will say in adolescents especially, I will still consider lithium since it is our gold standard treatment in adults. All right, so to sum up, pediatric bipolar is a chronic condition with discrete episodes of mania and depression. We've made some recent changes to the diagnostic criteria with focusing on these sort of discrete episodes rather than isolated manic symptoms. Consider ADHD and disruptive behaviors in your differential. It is associated with significant functional impairment and suicidality. Watch out for that. And then atypicals have considerable effectiveness. Lithium also has support. We need more research overall. And then this is just to plug a resource. The American Academy of Child and Adolescent Psychiatry has a bipolar med guide for families that is really good. And then here are references.